So how to reduce OR time using robotic system? There are various factors affecting the timing in operation theatre, starting from the anesthesia time, primary preparation, persons apart from the surgeon, surgical steps, time for the closure, discipline in operation theatre, and patient shifting. So considering the anesthesia time, if we have separate induction room and anesthetic assistant, definitely we can reduce the time of the anesthesia. And if we allocate a separate person for the preparation of tourniquet, side post for the leg support, and who will enter and register all the patient details in the system. The persons other than the surgeon, mainly the dedicated sister or brother who is trained in the robotic surgery and who knows exact steps what surgery is going to follow while doing the surgery. Maximum 3 persons per surgery, they are more than enough, so that everyone knows their role and what they have to do during the surgery. And dedicated assistant or fellow, if you have, he is always helpful so that he can irrigate, he can help you, he can do your closure and save your time. During the surgical steps, what is important, you have to plan the steps. You have to decide once you open the joint whether you will remove the osteophyte first, whether you will remove the menisci also, when you will put the pins, when you are going to put the sensors, femur first, tibia first, and how you are going to map the things. So you have to decide, you have to plan your steps, you have to follow those steps, and you have to repeat same sequence in each surgery so that all your assistant, they know that what you are going to do next, and they will give your scrub nurse, she will give you exact instrument which you want for the next step, and that will avoid the confusion. So time spent on the screen, keep this minimal, 2 to 3 minutes maximum. And to achieve this, you have to understand your robotic system fully. Quick changes like downsizing the femur, rotating the femur, decision about the tibial cut, flexion of the component, varus, valgus, kinematic arrangement, everything you can do within these 2 to 3 minutes if you know your system perfectly. More the number of cases you do, less will be the time required for balancing on the screen. And that's why use your system regularly for all cases, each and every case, use robotic system, don't keep it only for your difficult surgeries. So when on screen you see this, first screen you see that 4 narrow femur and 2 sides of the tibia is required, don't spend time here, just go to the next screen which will show gap balancing and shows that there is tightness present in the extension. And you know that whenever there is a tightness, you have to increase the distal femoral cut. So increase your distal femoral cut, and you will see that gap is perfectly balanced. From 4 degree varus, you will achieve the 0 degree. Another case is severe varus deformity, 75-year-old male, 20 degrees varus, bilaterally affected, walking with walker. X-ray show there are medial osteophyte and posterior osteophyte. Whenever there are severe deformities, robot will ask you the third axis, that is white side line, and it shows that there is 7 size of the femur and 5 size of the tibia required. But when you see the gap balancing, it will show that there is tightness present in the flexion. Whenever tightness present in the flexion, you know that you have to downsize the femur. So instead of 7 size, use 6 size of the femur, and that will balance your lateral side. I already told yesterday that in varus knee you have to balance the lateral side, and the medial side will get corrected once you remove all the osteophytes, menisci, and release the deep medial collateral ligament, and you don't have to touch the superficial medial collateral ligament in most of the cases. So 20 degrees of varus got corrected to 1 degree. Another case, well aligned and well balanced X-ray. Next case, severe flexion deformity. There is a 30 degree of flexion deformity along with varus, and further flexion up to 100 degree possible. Gap balancing shows that there is 30 degree FFD. The structures, they are tight in flexion on medially and laterally. Your window will show you that there is tightness present. Now whenever there is tightness present in extension, you know that you have to increase your distal femoral cut. So increase your distal femoral cut, balance on the medial side, and whatever tightness is present on the balance the lateral side, and whatever tightness is present medially, you can release the deep MCL, remove all the osteophytes from the posterior condyle, release the posterior capsule, and the deformity will get corrected completely. So similarly, you can see all these cases. This is the valgus knee. There is tightness present in extension and flexion. Whenever the tightness present in extension and flexion, you know that you have to increase the tibial cut. So increase the tibial cut, and you will see that gap is getting balanced, and you can have this perfectly balanced knee post-operatively. So there are various cases, n number of cases I can show you. When you use your system regularly for each and every case, you will be more confident, you will spend less time in balancing technique. Now, I will show you this case. See, 65-year-old female, 5 feet height, 112 kg weight. Screen shows that there is laxity present in flexion, and there is tightness on the medial side in extension. So, I balance this case, I use the tibial rods. Now how I balance this case is very important. This initial screen shows that there is size 4 femur required and size 3 tibia. Now as there is a laxity present in the flexion, so what I did, I used size 5 femur for balancing on the screen, and then my knee got balance on the screen and I got this correction. But what I did on table is little bit different. So when I use size 5 jig after taking the distal femoral cut, I saw that there is little bone present anteriorly and space is more, so I can downsize it. So in the same pinhole, I use the size 4 jig, and without disturbing my flexion gap, I can go with size 4 femur, which my robot showed initially. So this way, by combination of anterior and posterior referencing by robotic and posterior referencing are your jigs. So you can utilize both the systems simultaneously and balance the thing very well. So when you come to the cutting part of the system, everyone shows since yesterday that there are two different systems. You can use all burr, or you can use distal burring technique and use regular jigs. So use visualize cut mode for the tibia, apply and fix cutting jig with pins by using umbrella. Use saw to take tibial cut, recheck the cut by using umbrella, and any variation can be corrected by using all burr mode. Corey has larger size of the burr, much faster, and can use all burr mode to prepare tibia directly. So final fixation of implant. Keep required implant ready to open, cement mixing while surgeon gives wash with pulse lavage. Decide and follow same sequence while fixing the final implants. That means if I am doing PS knee, I always fix tibia first, then femur, and then I put the insert. If I am doing CR knee, I fix the tibia, I put the insert, and then I fix the femur. So if sequence, you know, if you are scrub nurse know, if you are implant person know, they will give same implant in your hand and you will save your time. Closure with the same steps, required suture material, stapler can be kept ready while fixing the implant. So what is the take home message? You can save time, definitely you can save time, and the discipline is the key for short surgical time and successful surgery. Thank you.